Good morning, guys. I hope we're all sparkly. Sea swim done with Her Royal Highness. 8.2 degrees today. It was a chilly one, but it was life affirming. Cold water swimming, I highly recommend it. Gym session done. So what next? Earn your reward. So I'm off to do emails. I had a little quick sneak peek before I left for the gym. A guy wants to come back to TMHC. What happened to him? Why didn't he want to continue gold standard therapy? Well, we got him dialed in, and the NHS looked at his blood test results and they said, "You're too high. You're too high. Your total testosterone is 35. Your free testosterone is 1.2. You're too high. You must stop therapy immediately." What did we suggest? We suggested lowering his dose. The logical thing to suggest, not have a knee-jerk reaction and go, you're too high. So as we've spoken about before, you can have negative health consequences as a result of having super physiological testosterone levels. But the premise behind TRT is normalization of your physiology and your psychology. What you need to do is carefully titrate your dose according to effect. And as you guys know, microdosing is the most effective way of doing that. So, what was the problem? Well, his levels were a little bit high. Don't really like free T's above 1. Normally guys who go, "I feel amazing," and we go, in our experience, you won't feel amazing soon. More often than not, a few months down the line, they say, "I've got anxiety. I want to lower my dose." So when you think about side effects, you think about the negative psychological aspect, but as you know, we need to look at biological markers such as hematocrit, lipid profile, etc., and blood pressure. So what was wrong with this guy with a free T of 1.1? Well, nothing actually. His hematocrit, lipid profile, etc. were normal. So why was there this knee-jerk reaction to a free T of 1.1? The answer to that question is I don't know. Perhaps they look at the reference ranges and think, obviously, you must be within that reference range because that reference range reflects everybody. Well, the reference doesn't reflect everybody, does it? It's a 95% confidence interval. And as we've spoken about before, reference ranges are lowering. Does that mean you have carte blanche to raise your levels to as high as you want? The answer to that question is obviously no. Because we know excess testosterone is deleterious to physical and psychological well-being. So we do regularly monitor parameters such as hematocrit, lipid profile, blood pressure, etc., etc. It's part of safe and effective care. So the logical thing to do was say, okay, speak to your private provider and see what they say and let us know what they say, because we share care. Now, the ultimate responsibility is ours, but obviously if your GP has been kind enough to do bloods, there is a sort of duty of care for them to say, well, I'm not really sure. So this guy was referred back to the endocrinologist, who freaked out. Now, endocrinologists, they are supposed to be experts in what? Yeah, you guessed it. Hormones. Now, do they know anything about testosterone replacement therapy? The answer to that question is no. Do they? No, they don't. I mean, I've heard so many horror stories. One guy got stable on testosterone replacement therapy and was told, well, you're stable now, you don't need to continue. Now, you just need to have a basic understanding of the HPG axis to realize that if you utilize exogenous testosterone, you're going to suppress the hypothalamus and pituitary. So no longer send LH and FSH down to the testicles to produce testosterone. So you don't start therapy, get stable, and then stop therapy. You're going to render that guy hypergonadal, iatrogenic. You are actually causing harm. How ludicrous is that? This is not an isolated story. We hear these sorts of stories all day, every day. because there's a fundamental lack of understanding and awareness surrounding testosterone deficiency and TRT. Now, as I've said before, there are British Society for Sexual Medicine guidelines to help facilitate people safely and effectively diagnose and commence therapy if indicated. So you get a diagnosis. The first thing is not to think, I'm going to jump on testosterone replacement therapy. The first thing is to think about is there anything I can do to normalize my levels so I don't need TRT? That's your clinician's job. So don't think I qualify for TRT because I've got testosterone deficiency. Think, is there something I can do to prevent me from starting this lifelong therapy? Logical, because to feel the benefits of TRT, you're going to have to do these things anyway. Lifestyle, diet, exercise. If your thyroid is dysregulated, you're going to have to normalize that to do what? To feel good. Because as we've said before, the foundation hormone may well be testosterone from an anabolic perspective, but your body's a little bit more complicated than just banging some testosterone. Your dose needs to be carefully titrated according to effect. Much like if you have hypothyroidism, your dose needs to be carefully titrated according to effect. Much like if you have diabetes, your dose needs to be carefully titrated according to effect. Because every hormone needs to be in balance to feel good. Isn't it ludicrous? Honestly, I did consider doing a master's in endocrinology. What the hell's the point? Endocrinologists do not understand the fundamentals of the HPG axis. I mean, some do, but my word, we hear so many horror stories. It is beyond belief. So the focus of attention of endocrinology is not obviously testosterone deficiency. It is what? Diabetes. Now, diabetes is a serious health problem and needs to be addressed. Now, what happens when you have diabetes? Insulin resistance. So what is insulin? An anabolic hormone. What's going to affect the HPG axis as well as everything else that we speak about regularly? Insulin. So are you going to render yourself hypogonadal with diabetes? Yeah, actually, that is part of the mechanism. The other part of the mechanism is the fact, obviously, your metabolism is dysregulated. You're going to become a chunky monkey if you're type 2. And what happens to the chunky monkeys? They create excess adiposity, and that's going to create excess estradiol in both the adipose tissue and the liver, and that's going to feed back to the hypothalamus and pituitary to trick the brain into thinking that you have enough testosterone. So you're not going to send LH and FSH down to the testicles. Your testosterone is going to lower. And are you going to be motivated to do more exercise? Are you going to be motivated to make the right choices in your diet? No, because you've got low testosterone as a result of having high estrogen. It all fits into place, doesn't it? So when you think about endocrinology, it should be a holistic approach. It shouldn't just be diabetes. It shouldn't just be thyroid. Your endocrinologist should have an understanding that all hormones are related, whether that be direct or indirect. And if you positively impact one hormone, as in you normalize it, then that will have an impact on other hormones. So one of the fundamental problems of medicine right now is the fact it's becoming far too specialized. And specialization means you're specialized in one thing. When it comes to endocrinology and your hormones have autocrine, so they have effects on the tissue that they're produced in, paracrine effects on neighboring tissues, and they have endocrine effects. And there are complexities involved, such as estradiol having its paracrine effects and autocrine effects, not realizing that it also has endocrine effects, because why else does estrogen negatively impact the hypothalamus and pituitary in obese people outside of what we've talked about, insulin? Yes, estradiol. The estradiol that's produced as a result of excess aromatization because you're chunky tells the hypothalamus and pituitary that you have enough testosterone. So these people on the internet, oh, estrogen's just a paracrine hormone, or they say intracrine. They're idiots. They don't know. Don't listen to people on the internet. Should you listen to the endocrinologists? Well, what the hell? Bit worrying, isn't it? It's a bit worrying when the gym bros know more than the endocrinologists. So what are we trying to do? We're trying to disseminate information, education, and hopefully we can positively impact a change to the individual watching this video. And hopefully with the BSSM, we can positively impact a change to the endocrinologists who appear like headless sheep. It's really a lottery as into whether you have a supportive endocrinologist or not, or urologist or andrologist, who has an awareness of the HPG axis, who has an awareness of the fact that you need to look outside of this one field and look to other metabolic markers, look to adopt a holistic approach to lifestyle, diet and exercise, not just reach for the prescription pad, but give appropriate advice to help that person get healthy. Our role is simply to support people, not just dish out drugs. You only dish out drugs if you need drugs. Less is more, unless it talks about sex. Anyway, I've rambled enough. I hope you have a sparkly day. And remember, stay healthy, stay happy, and stay strong. There you go, Felix.